Dear colleagues, I invite you to our session on neuroendocrine tumors, and I will give a short introduction now. After me will be speaking Professor Baum and then Masha from South Africa, and I will do the third lecture of this session. In my introduction, I would like to remind you that when we talk about theranostics in neuroendocrine tumors, we are talking about somatostatin receptor-based radioligands, and then there are a couple of non-somatostatin receptor-based ligands nowadays. Just a short and quick summary. The somatostatin receptor-based theranostics are based on the binding of a somatostatin receptor ligand to somatostatin receptors expressed on the tumor surface. And with neuroendocrine tumors, mainly we talk about the somatostatin receptor subtype 2. Now, after these actions, there comes inhibition of the cellular pathway, which is not so important for our imaging and therapy. As a short reminder of the history, we do have now many years of experience with somatostatin receptor-based diagnostics and almost 25 years of therapy. We have a lot of radioligands known and a lot of studies published. And now, after many years, we are able to talk about registered ligands. When we look at the gallium-labeled somatostatin receptor compounds, one of the major advantages is that we will get the image already one after injection of the radioligand, whereas, for instance, compared to octio scans 30 years ago, we had the image only 24 hours after intravenous injection. So we have registered products now, SomatoKit in Europe and Neospot in the US. We have registered germanium-gallium generators. And we have a nice study published on Thera, which had shown that the patients who receive the radioligand do much better than those who receive only placebo, always in conjunction with the unlabeled ligands. Now, most of the studies originally come from Europe, spreading all over the world. For instance, in the States, we have so many centers now administering lutetium dotatate. So this is a great success that we are having over the recent years. This is just some history here, starting from Europe to everywhere in the world. And this makes our World Association of Nuclear Medicine, our WORMs, very important also. We have different radioisotopes and different ways of administration, intravenous, intraarterial. So we did a lot of studies. So this is just a mention on the radioligand. On the other hand, I would like to point your attention to the grading system of patients with neuroendocrine tumors. So most of the studies published and most of our experience is based in patients with G1 and G2 neuroendocrine tumors. This again is the NETA study leading to commercialization of the radioligand product. And with this, peptide receptor radionuclide therapy has entered the guidelines of ENETS, of NANETS, and many other guidelines are now existing, showing us the wealth the value of PRRT in neuroendocrine patients, but also studies coming up in lots of other tumor entities. Now we are looking forward to some results of the NETA trial, which is currently performed with Thera in grade 2 and grade 3 endocrine tumors. Always have in mind that we sometimes compare results from Europe and the US. We compare SPECT and PET, and also in Europe, we mainly perform dual tracer imaging, which means somatostatin receptor PET and FDG PET. And I dare to say that we sometimes compare apple with oranges and sometimes strawberries too. So thank you very much for listening to my introduction. And now we are awaiting Professor Richard Baum's talk on new developments in imaging and PRRT of neuroendocrine tumors. Thank you.
Hello, everyone. It's a great pleasure to speak at the ICRT meeting. I'm Richard Baum, the previous president of Worms. And the first topic actually is new developments in imaging and PRRT of neuroendocrine tumors. So I just would like to remind you that it is now actually 30 years since the first ocular scans have been used in 1990. And it's a long way since then. And you see the major milestones here, like the use of yttrium-90 DOTA-TOC and later on lutetium DOTA-TATE, but also a lot of clinical trials which have been performed actually by Eric P. Granning at the Erasmus Center in Rotterdam. Now, what are the advancements in diagnostics for neuroendocrine tumors? First, I will speak about PRRT of G3 neuroendocrine neoplasms, then about intraarterial PRRT of liver metastases, about new end agonists like NODAGA, LM3, and DATA, LM4, and then on alpha PRRT using actinium-225 DOTA-TOC. I will also shortly elaborate on scandium and terbium DOTA-TOC, and at the very end say a few words about molecular profiling of neuroendocrine tumors, looking at somatic and germline mutations. So we have published two major papers last year and actually this year on PRRT in grade 1 NET in the Journal of Nuclear Medicine, as well as on the prognostic value of FDG PET-CT in a large cohort of patients. And we have analyzed our patient cohort at my previous center in the Zentralklinik Bad Berka and found out that even in G3 NEN, which are commonly not considered as a target for PRRT, we can achieve a median progression-free survival of 9.6 months and a median overall survival of 99 months, which is quite similar to results reported by the Nordic group. And we suggest the following treatment decision algorithms for G3 NEN. First, you should look at the proliferation rate. It's Ki-67, which can be between 20 and 55% or over 55%. If it is over 55%, you should just go to the neuroendocrine multidisciplinary tumor board and select the appropriate chemotherapy, which can be, for example, cisplatin etoposide or other methods. And if the Ki-67 is between 20 and 55%, you should do staging with FDG PET-CT and somatostatin receptor PET-CT. And depending on the results, if you have somatostatin receptor positive metastases, you do PRRT in the patient, and if you have both FDG and somatostatin receptor PET positive, you probably start with CAP-10 and then follow by PRRT and then do restaging again. The next topic is intraarterial PRRT. It has been shown quite some time ago, 10 years ago already, that if you administer, for example, gallium-68 DOTA-TOC intraarterially, you get much higher tumor uptake, up to 3.75-fold higher uptake in the metastases as compared to the systemic route. This was shown by the group from Heidelberg. And that is actually the reason that this first pass effect, how we call that, can be used to get higher doses to the tumors. Now, we have performed a number of treatments and compared intraarterial versus systemic in patients with neuroendocrine liver metastasis only, and in patients with extrahepatic disease present. And first of all, you see that intraarterial therapy is much more efficient. And secondly, that people with liver metastasis only live much longer. The next topic is actually somatostatin receptor and agonist. And this was shown by the group from Bern, by Jean-Claude Royb's group, that surprisingly, and agonist labels more SST sites than agonist in human cancer tissue, shown here for ileum carcinoid comparing DOTA-TATE, labeled with lutetium autoradiography, and DOTA-BAS, which is an agonist. And we have been actually the first group in the world using the agonist, and could show with GR11 and later on with Nodaga LM3 that you can detect liver metastases much more efficiently because the background in the liver is less than with the agonist, as shown in this case. And also, if you look at the bone metastasis in our hands, the antagonist LM3 was more sensitive in detecting bone metastases, as shown in this patient with paraganglioma, compared to DOTA-TOC PET-CT. What is more important than imaging actually is that for therapies, the antagonists have a much longer residence time in tumor, as you can see here for JR11. These are data from the University Hospital of Basel by Guillaume Nicolas. And also that the initial uptake is higher as compared to the agonist. And we have performed already treatment and dosimetry comparing LM3 versus DOTA-TOC. And you can see easily on the right lower side that the mean absorbed dose is up to 8-fold higher for liver metastases, and especially also for lymph node metastases. So in 61 patients, we looked at the antagonist used also intraarterially. So this is a very nice case with gallium Nodaga LM3 PET-CT, showing very clearly liver metastases in the patient, which are hardly seen. Only one is faintly seen on the DOTA-TOC PET-MR in this study. And then under treatment intraarterially administered lutetium LM3 shows very nice uptake in the liver metastases with a SPECT-CT. And we have published other patients also just recently and could show that, if you look at the right side, this treatment was very successful. That means there was a complete remission of the liver metastases, which is ongoing in this patient after intraarterial and agonist treatment. The next topic is alpha PRRT, and again by the group from Heidelberg, it was shown that, for example, high doses of bismuth 213 DOTA-TOC can overcome the resistance of yttrium-90 DOTA-TOC, as shown in this image of the year already in 2012. And again, we have treated quite a large number of patients with intraarterial actinium DOTA-TOC. This is a very nice case, a patient we started treating in July 2005 with a number of liver metastases using lutetium DOTA-TOC, and then the patient had a complete remission in actually October 2007. Then recurrence, we treated again, yet again the patient partial remission, and so on and so on. And you see in January 2018 and compared to September 2018 on the right lower side, there was a very fast progression of the disease despite the previous treatment with lutetium DOTA-TOC. So we decided to go on with alpha PRRT using actinium 225 DOTA-TOC, and as shown in these images, there was again a remission of the disease after use of the alpha emitter. So what else is on the horizon? There are new radioisotopes, which are so-called theranostic radioisotopes, which can be used for imaging and probably also with a different isotope for therapy. We have published already some time ago the use of scandium-44 DOTA-TOC in metastatic neuroendocrine tumors, and just recently have been using terbium. So terbium is called the Swiss Army knife of nuclear medicine because it has, as you can see here, with terbium-149 an alpha emitter, then with 152 positron emitter, with terbium-161 an Auger emitter and SPECT imaging agent, and also with terbium-55 a SPECT imaging agent. And we have published in a very nice collaboration between Christina Müller and Nicolas van der Meulen's group a study on using terbium-152 DOTA-TOC, which is interesting because it has a long half-life of 17.5 hours, and especially looking at the new total body PET-CT machines that might be very interesting for predictive dosimetry. We are just in the process of submitting a paper also on terbium-161 DOTA-TOC. Again, a very nice collaboration between Christina Müller's group at the Paul Scherrer Institute in Switzerland and my previous center. So I will come to DOTA-TOC, which you all know. DOTA was most frequently used chelator, which is very versatile for imaging and therapeutic radionuclides. And recently, Frank Röst's group has developed a new DATA, not DOTA, but DATA hybrid chelator, which is shown here, which has the advantage of being able to label peptides at room temperature and not to use heating at 95 degrees as for the DOTA. So there are some uses of gallium DATA-TOC, and actually I studied the first patient, and also a larger series just recently published in the European Journal of Nuclear Medicine Molecular Imaging by the group from Chandrasekhar Bal in India. And as you can see here from the data, the uptake in the liver is somewhat less than with a DOTA component. And this is shown in our patient, which we studied first, that you have less liver uptake and can probably detect liver metastases more clearly, in addition to the advantage of being able to label at room temperature. And we are just now in the process of using ASTA, which is another chelator, which is very convenient for labeling with lutetium, with alpha emitter actinium, and also with scandium 44. One last slide I will show on MDS leukemia, which is frequently discussed, especially by the oncologists, as a rare adverse event. We recently finished a large study in 1,631 patients over 20 years, which was published by Maitini Shantadisai from, and she looked at these patients, and we selected all patients with MDS or acute myeloid leukemia, and we found it was a quite rare event, but the prognosis of these patients, of course, is not very excellent when they suffer from this adverse effect. I would like to finish with a recent review paper on molecular profiling of neuroendocrine tumors to predict response and toxicity to PRRT, which was published in The Lancet with Lisa Bodai as first author. And as you can see, there are a lot of pathobiological features, pathway, and candidate genes of radiation sensitivity and toxicity, which can be considered. And I'm very much convinced that in future, we will not only use the uptake, the SOV, for example, on the PET images to select patients for PRRT, but to look also at other prognostic factors, which are mentioned here. And some of the most important could be discovered using the NET test, which was tested in actually 3 centers in Italy, in Germany, and in the Netherlands. And we found out that this test can really predict the efficacy prior to therapy and individual assess the therapy response after PRRT. So this is, I think, what you need to deal with in the next months and years, that we are more looking at mutations, somatic mutations, as well as germline DNA changes to really select the best patients for PRRT, in addition to what we know from the molecular imaging field. Thank you very much for your attention.
So, dear colleagues, I will now go on with non-somatostatin receptor-based theranostics. In fact, there are some more than are listed here, but I will concentrate this short conversation on MIBG, on gastrin-releasing peptide receptor antagonists, and on cholecytokinin receptor agonists-antagonists. At the University of Innsbruck, we have always been using gallium DOTA TOC PET-CT for considering a patient for PRRT. And if the TOC was not sufficient, we were using lanreotide-based diagnostics. Yeah, but in fact, for many years, the only registered therapy was based on MIBG neuroendocrine tumors. In fact, for instance, in patients with pheochromocytoma and paraganglioma, we are entering now a new therapy paradigm from the old concept of 1,2,3 iodine, 1,3,1 iodine MIBG, the old concept. We are having and exploring now patients with these rare neuroendocrine tumors with gallium and lutetium theragnostics. Just here is a small cohort of the rare disease metastatic phemochromocytoma imaged in Innsbruck. Usually in these patients, they are living, have a long life experience, and there are a lot of diagnostic agents that are considered for localizing the disease. MIBG is one of these. And even if you do MIBG scintigraphy, compare gallium, DOTA-TOC, and FDG and FDOPA, you may have very different and diverse results in one and the same patient. Here is one patient whom we know since 30 years now, and who was always treated with single cycles of MIBG, had good or partial response. This is the therapy schedule over many years. And in this term of therapy, he succeeded very well together with high dose 131 MIBG therapy. And all these scintigraphic evaluations, he survived more than 30 years, is still alive. So you see the very complex therapy scheme in this particular patient. But I want to point out there was a point when we had considered that not all patients and that not all lesions were were MIBG positive, and we did the gallium DOTA-TOC PET scan, which was quite which did not take up very good the radioligand. So we still considered to go on treatment in this particular patient with MIBG. This is now when in the final end, the patients had undergone surgery, external radiotherapy, and still after combined interventions showed a response to combination therapy. Here's another example of a patient with pheochromocytoma. You see positive MIBG images and positive DOTA-TOC images. And in such a patient, one may consider the combination of MIBG and Lutathera, for instance. Here is another patient who was treated, who had paraganglioma, and he was MIBG positive and responded to MIBG treatment only after initially, and then had also yttrium DOTA-TOC treatment, to which he responded very good. But in fact, we do not have a lot of results in patients with MIBG and with pheochromocytoma and paraganglioma, as these patients live long, and also they may live long without treatment. So one has to be very careful in considering any radionuclide therapy in these particular patients. I now want to talk a little bit on clinical studies on the gastrin-releasing peptide receptor agent. This is developed by AAA. Now, in the first study conducted in Innsbruck, the so-called Mitigate study, which was sponsored by the European Community, we first administered this particular compound, NeoBOMB1, an antagonist to patients with histologically confirmed advanced gastrointestinal stromal tumors. The substance is stable in blood, and it is excreted into the urine, binding to the receptor in vivo is quick, and elimination is mainly via the kidneys. In the first administration, we also had all the safety studies with the patient protocol. I would just overgo this. And here is one, the very first patient studied with neobomb, gallium labeled, a patient with a single liver metastasis and the peritoneal mass, as seen here on the CT. Quick elimination and uptake of the substance. What you see here is also quick uptake by the liver metastasis, but unfortunately, no uptake in the peritoneal mass. So this was our first patient studied with neobomb in Innsbruck. Regarding the tumor uptake is sufficient or seems to be sufficient, but in all patients so far, we have also seen high pancreatic uptake. And also the ratios between pancreas and liver, for instance, as shown here for the caput pancreatis, seems to be high and frightening, perhaps, when we think of radionuclide therapy. But on the other way, the first study has shown mitigate that we have acceptable organ biodistribution despite of the very high pancreatic uptake. But the substance is clinically safe and no side effects were seen with gallium neobomb 1. Now, in animal models, it seems to be, it was shown clearly that tumor uptake increases with time, whereas pancreatic uptake decreases with time. This is especially important when we think of a lutetium-labeled neobomb product for future serum studies. The first abstract was presented at the SNMRI and also at ENETS, showing that patients, for instance, with breast cancer may take up the neobomb significantly. In fact, these receptors are expressed on many tumors, such as also neuroendocrine carcinomas. But there is still a long way to go, and the clinical trial with lutetium, the so-called NeoRay trial, is recruiting currently. Now, a last word to the cholecystokinin receptors subtype 2, which are expressed on medullary thyroid cancer, which is a neuroendocrine tumor of the thyroid. Several analogs exist. The first analog that was studied in the so-called TransCan study, CP04, had shown by conventional imaging after labeling with indium that the tumor lesions may take up this compound. Now, many mini-gastrin analogs were developed, and one was recently presented and patented in Innsbruck, which is the MGS5, mini-gastrin S5, a mini-gastrin, which can significantly be taken up by tumor lesions, tumor cell lines, also in the lutetium-labeled form. This is our very first patients studied recently with gallium daughter-linked mini-gastrin S5 at Innsbruck. You see lesions that were not seen by F-DOPA, which is the radioligand that is most used in patients with medullary thyroid carcinoma. But also some of these lesions who were DOPA positive did not show up on this mini-gastrin analog. Here is another patient with significant uptake of this mini-gastrin analog in the liver lesions. So this uptake seems to be high with SUV values of 20-40, which is high and probably enough for therapy of these patients in the future with a lutetium-labeled analog. So now ending this session, I thank you very much for attending the session. Greetings from Innsbruck. See you. Bye-bye.
Good morning, good afternoon, and good evening to you. I am going to discuss the therapeutic approach to metastatic NET with emphasis on theranostics. On the next slide, you will see the approach to metastatic NET. It starts from the diagnosis to the imaging as well as to the various treatment modalities. Under diagnosis is a host of different doctors that are involved, including the surgeon and the histopathologist, imaging, the radiologist, ultrasonographer, the nuclear physician, and treatment, the nuclear physician, endocrinologist, and oncologist. On the next slide, you'll be able to see that this is actually a multidisciplinary interaction-based treatment. There's interactions between the pathologist, the oncologist, endocrinologists, nuclear physicians, as well as the surgeons. So in the case of neuroendocrine tumors, it becomes our patient. Metastatic NET, on the next slide, at diagnosis, 20 to 40% of cases present with metastasis. The most common cycle for metastasis is the liver, which carries the worst prognosis. If metastatic disease is localized to a specific area, or more than 70% of the tumor burden can be resected, cytoreductive surgery should be considered. The current 5-year survival for localized disease is extremely good, with 78 to 93%. Metastatic NET previously was very poor at 19 to 38%. But in the last 2 decades, the survival has increased, and some report greater than 50 to 63%. And this can be attributed to advances in imaging techniques with early metastatic detection, cytoreductive surgery, and the introduction of PRRT. Next slide. Just briefly summarizing the pathology of the neuroendocrine tumors, which is actually some of the basis for the treatments and the different management. Its morphological features are distinguished between well-differentiated and poorly differentiated tumors. And you can see with the well-differentiated tumors, there's a salt and pepper chromatin of the nuclei versus the poorly differentiated tumors where there's nuclear molding. Next slide. There are 3 main types of staining for the pathology, and the 2 that we would look at is chromogranin and Ki67, and the other is the synaptophysin. The Ki67 is an indication of the proliferation of the tumor, which is very critical to treatment. Just an overview of the WHO characterization. They classify versus the site of the tumor, and also on the morphology and the mitotic activity of the tumor. Now, based on this, we know that there are personalized mutations or tumor heterogeneity, and this can be intratumoral, intermetastatic, intrametastatic, and interpatient. And because of this, imaging protocols are very important. So the current imaging protocols can be SPECT, PET-CT, and also multiple newer agents that are being developed. The net PET grading with FDG versus SSR receptor imaging has been critical to managing patients with metastatic neuroendocrine tumors. And the reason for this is to determine the response that these patients will have to particular treatments. So obviously, if the patient has more SSR positive tumor, this patient will then respond to PRRT and somatostatin. Whereas if the patient is more FDG positive, this patient then will respond more to chemotherapy. The first case that I want to show you is an intra-subject heterogeneity and the evolution of disease over time. And here is a young female, 36 years old. And if you see in the images at 20 months post-diagnosis, she has a very strongly positive SSR NET. In fact, the histology showed a mitotic index of 1% versus the FDG, very lowly avid in segment 6. Subsequent to this, at 40 months, this completely changed. So you can see that in the left lobe of the liver, there's a strongly positive FDG avid lesion as compared to previously. And on resection of this lesion in the left lobe of the liver, the Ki-67 index was actually 30%. So this proves intratumoral, intermetastatic tumor heterogeneity. And obviously the management changes for this patient as well. One of the groundbreaking studies that introduced PRRT was the NETA-1 study. And this basically had two groups, one with PRRT and long-acting octreotide and basic standard of care versus high-acting octreotide. So first group, group A versus group B. And group A with PRRT outweighed group B, all in the progression-free survival, significantly higher response, overall survival improvement. In fact, by 20 months, group A had only 30% deaths recorded, and group B had 50% of deaths recorded. So this was a 79% reduction of deaths in group A with PRRT. Also, there was a significant benefit in terms of the quality of life, and only 2% in group A suffered from severe bone marrow toxicity. In terms of long-term studies, 12-year retrospective study demonstrated efficacy of peptide receptor and radionuclide treatment, and the key findings was prognosis was progression after early treatment, good prognosis, females and patients with no more than 2 tumor sites. And they proved relatively stable tumor situation can be achieved over many years in a large number of patients. And there was a positive effect of PRRT in terms of the quality of life for these patients. Salvage therapy has been also proven to be very safe and effective. Here I present a study with a good number of patients, 181 and 168 in bronchial NET or GEP NET respectively. And these patients all had a good response after the initial PRRT. And subsequent to that, in time, they had progressed, so they were considered candidates for the study. And they all had retreatment, and some had retreatment with PRRT. And they found that the safety appears to be similar to that of the initial PRRT, with no higher incidence of AML or MDS being observed. And also no grade 3 or grade 4 renal toxicity occurred with after the retreatment. In certain centers, yttrium is available, the yttrium-based PRRT, and you can clearly see the difference between the lutetium versus the yttrium in terms of its toxicity. The yttrium outweighs the lutetium and is the more toxic. Dosimetry and tumor absorbed dose calculations. Currently, there are no universally accepted standardized protocols. And the reason for this is because there is no standardized way of quantifying the dosimetry for these patients, be it patient-specific characteristics and biological or effective half-life, depending on also on the imaging point times that are taken for dosimetry. So we find that in the IAEA, EANM, and the SNMI guidelines, they recommend that patient-specific dosimetry be performed if feasible. The first case I want to present is a 62-year-old female with carcinoid tumor who had a partial gastrectomy. This patient subsequent to that had elevated chromogranin, and as you can see, there is discrete focal activity in the gastric bed. On endoscopy, this could not be visualized. So the patient subsequently went on to monthly sandostatin, and the chromogranin reduced, and on repeat scan, you can see complete response in this lesion. The next case, a 36-year-old female who in 2012 presented with lower lip swelling. At that time, she was actually treated as an allergic reaction or angioedema. Multiple resections of the lip did not reveal anything convincing. In 2015, after this had progressed, she was then investigated for sarcoid, and they found on ultrasound the pancreas had been enlarged, and they had multiple biopsies taken, which confirmed a neuroendocrine tumor. At this time, however, the tumor had already extended into the spleen with extensive tumor portal vein thrombus seen as well. The histology also confirmed post-Whipple's procedure, the tumor excision. Post-Whipple's procedure, incomplete tumor excision with vascular invasion. Her Ki-67 was 20%. At all times, the patient tumor markers were normal and non-functioning pancreatic neuroendocrine tumor with a moderate grade. So on the octreotide scan, you are able to see that she had positive SSR2 receptors. And in view of the Ki-67 index, we had then decided on using a combination of lutetium dotatate as well as temozolomide in the multidisciplinary team. Subsequent to this is the post-therapy scans, cycle 1, right down to cycle 4 of treatment. And you can see almost complete improvement in the lesion of the pancreas. And subsequent imaging, you can actually see post 1, 2, and 3 cycles. So it's not unfamiliar, chemotherapy and PRRT in combination can be more effective. And in fact, the combination can be more effective than PRRT alone or chemotherapy alone in selected patients. The next case is a 56-year-old female with metastatic pancreatic NET with liver mets, Ki-67 index 2%. Patient also underwent Whipple surgery. Chromogranin level was 4,888. Patient was placed onto Xeloda, somatoline, and had 3 cycles of lutetium dotatate. So here you can see this is the pre-therapy scan, and she had large SSR positive lesions in the liver. And subsequent to 3 cycles of treatment, there was a good response in majority of the lesions. So the slide below is pre-therapy, and the slide above is post 3 cycles of therapy. So at this point, it was considered that this patient, because the lesions were small enough in the liver, the TheraSpheres were used in combination with Xeloda and temozolomide. And subsequently, there was a significant improvement in the remaining lesions as well. So it's not uncommon to use combination treatments, particularly in the liver. And one of the trials we are awaiting is the Lucia trial, which is going to show us intraarterial versus standard intravenous administration of the PRRT. And this this is a multi-center study, and they selected 26 patients with progressive liver dominant unresectable grade 1. Grade 1 or grade 2 NET, predominant liver disease, and the endpoint is the difference of the tumor to non-tumor ratio of PRRT uptake. Secondary endpoints will also include the tumor response, toxicity, and uptake in the extrahepatic lesions and the renal uptake. So we're looking forward to the outcome of this study to assist us in liver-burdened metastatic neuroendocrine tumor. The next patient is a 56-year-old male known with inoperable carcinoid tumor, presented with progressive periorbital edema and subsequent left eye infection, progressive diarrhea, flushing, loss of weight, dizziness. As a result of the diarrhea, he presented with hypokalemia, repeat hospitalization for hypoglycemia. Octreotide imaging showed SSR positive lesions in the lung, liver, bone, and abdomen. And he was placed on somatoline, Zometa, and lutetium was given for 4 cycles. So what we're seeing right now is the pre-first cycle of treatment. This is prior to treatment, and if you can appreciate the periorbital edema in this patient. Subsequent to this, day 1 post-cycle of the first injection, immediately there is a good response and reduction of the periorbital edema. And day 5, almost complete response. In fact, he actually called that normal in terms of his normal appearance, and he was very happy. Including with that, prior to therapy, his potassium was 3.2, and this was on potassium replacement. Post-therapy, it went to 5.1 with no requirement for potassium replacement. Randomized glucose prior to therapy was always unrecordable, and he was always placed into glucose infusions. But post-therapy with no glucose infusion, his glucose was 10.4. Serotonin also after the first cycle was pre-first cycle was 14,812, and post-therapy went down to 3,985. The last case is a 73-year-old male with metastatic carcinoid of the small bowel, positive chromogranin, low-grade tumor. In 2009, had resection of small bowel, and in 2014, he had portal vein embolization with right liver resection and cholecystectomy. He was placed on sandostatin from 2009. On the gallium-68 dotatate PET CT, it showed progression in C2, left lung nodule, left adrenal gland, and mesenteric nodes. So the patient was then put onto lutetium 4 cycles, and on the 6th month follow-up after the initial PRRT, he remained with stable disease and sub-centimeter mesenteric nodes. He was then continued on sandostatin, and subsequent to that, you will see that he continued to remain with stable disease, and even now, currently 3 years ongoing, continues with stable disease on sandostatin treatment. So beginning the summary, the largest slice is actually the individualization of treatment for each patient. Primarily, surgical resection and cytoreductive surgery is a gold standard and should be done even if there are metastatic lesions that are localized and can be excised, or at least more than 70% of the tumor burden can be surgically removed. Imaging parameters are important for protocols, so your octreotide, your MIBG, your PET CT protocols, your NET PET protocols will guide you in the management and the approach to these patients. Also, your patient clinical and histological parameters. So in the clinical profile, your patient may be not a candidate for chemotherapy or surgery, and then this patient will definitely be managed differently as compared to others. Modifying pharmacokinetics would include your immunosterol that you would give to the patient to promote and enhance the renal output during treatment. Patient individualized dosimetry is also has to be considered, and combination of treatments as adjuvant must also be considered with patients. In summary, the therapeutic approach in metastatic neuroendocrine tumor firstly must be a robust histology and imaging protocol to distinguish tumor heterogeneity and the tumor proliferative index. Again, if the metastatic disease is localized or if more than 70% of the tumor burden can be resected with cytoreductive surgery, it should be considered. Now, PRRT has proven to be play a leading role in metastatic neuroendocrine treatment with improved progression-free survival, overall survival, improved quality of life, excellent palliation, and few side effects. Salvage therapy, retreatment, and retreatment with PRRT appears safe as well as effective. The current lutetium PRRT research investigations that are going on would be the low-dose multiple cycle approach, intraarterial PRRT versus the intravenous PRRT, particularly for liver-burdened tumors. and individualized dosimetry. There is also evidence-based experience that combination of PRRT with other conventional treatments such as chemotherapy and high-dose sandostatin are effective and safe with good clinical outcomes. Thank you so much for attending this talk, and I hope that you've learned and that your center will benefit from this discussion. Cheers.